We'd like to welcome back to the show Dr. James Kimmey, the former president for the Missouri Foundation for Health and with St. Louis University. Thanks for coming back to the program. I know from last time, the best question I could ask you right now is, what did we miss?
Well, it's not so much what we missed. We had a tremendous amount of information in these presentations, and I think it's very important to the audience to have a good understanding of primary care. I think in the first presentation, it's mentioned it's about relationships, and it was mentioned that it was about trust, and I think those are very important. But you can have a relationship with the team, and several of the speakers talked about the team approach to primary care, and they have now what's called the patient-centered medical home. The Affordable Care Act is actually promoting that rather substantially. And in that medical home, you've got not only the physician, you've got nurse practitioners, you've got social workers, you've got care coordinators, you've got a variety of different people who are members of the team. And so the individual who's going to the doctor relates to that team. Now the advantage for the doctor, because you talked about burnout earlier, the advantage to the doctor is that many things can be given to the team to do. So from the patient's perspective, they're in contact with a variety of people who have their interests. They're right in the center of this, but it doesn't have to be the doctor all the time. And so a lot of the follow-up, and this was mentioned again by some of your speakers, a lot of the follow-up can be done by some of the other members of the team. So the patient-centered medical home is important. But you also needs to be in a medical or a healthcare community where you've got hospitals and specialists and you've got a public health department. And you begin to link these things together, as a few communities in this country have done. Not many, but a few have done it, where they've really linked public health, prevention, primary care, and then the rest of the healthcare system together to get a more efficient, effective way of taking care of people.
Is there resistance to what you're talking about here?
It's hard. It's complicated. It's not traditional.
Not the way we've done it.
It's not the way we've done it. We've always done it the other way, and so that's the way we do it. But that's breaking down, and so we're seeing a lot more creativity right now, some of it driven by funding in the Affordable Care Act, to really begin to try some of these newer, different things. And I think another important point that was made here is that good primary care is good quality care, and good primary care is less costly care. There have been studies done. There was a study done on one of these patient-centered medical home projects in which they demonstrated that the patients in that program were 18% less likely to be be hospitalized. They were 36% less likely to be re-hospitalized, in other words, having a problem, and the costs were 7% less. Now, if we get those kinds of results across the country, in a big system like healthcare, 7% savings, not shabby. That's pretty important stuff.
I want to ask you if we should be thinking outside the box even more based on what we're seeing on Twitter. Are you talking about how a team can provide that relationship? It doesn't have to be just the individual, but should we be talking even more outside the box about what preventative care is? Are parks, they're talking on Twitter, parks, bikes, lifestyle, things like that. Is that something that should be in this healthcare conversation?
No, that's very much a part of the conversation. And a well-established medical primary practice of the kind that we're talking about here, the medical home, the organized practice, does preventive work. They do counsel people about exercise. They do follow their weight. They do those things. And that's why you get this better quality output from that kind of system.
So how do we get more people, whether it be doctors or nurse practitioners, how do we get more people in the pipeline to do something about this shortage?
Well, I think we've got a lot of people on the front line, who is one of the panelists mentioned. The Practice Act in Missouri for nurses is very restrictive, one of the most restrictive in the country. We are not going to be able to have the traditional model of Marcus Welby, one doctor per person. We've got to open it up and look to nurse practitioners. We've got to look to physician's assistants. We've got to look to all of these people on the team to augment the primary practitioner, whether it be a physician or nurse practitioner. They need augmentation to prevent burnout.
Okay, give us, let's stick with this solutions theme. What else did you hear in tonight's show? What else would you have liked to hear in tonight's show? We have about 60 seconds.
Okay, I think one of the things we didn't hear much about is what a barrier insurance is to good primary care. The insurance system is based on fee-for-service and piecework. You touched on it in your introduction. And that's the way we do it in this country. That's a tremendous barrier, but that's the way the insurance companies drive it. They don't pay to keep people well. They don't pay physicians to spend a lot of time with patients. They pay service by service, test by test, and that's the way you run up tremendous costs to minimal benefit. To
That's
the
not the
patient.
market at work? That's not just how things are done
Oh, the
naturally,
market-
naturally
no.
happen?
The market doesn't work in healthcare. Let's face it. You don't have a choice when you need the healthcare and the medical care. You don't have a choice, so you don't have a market. I think that the market in healthcare is a myth. It's perpetuated by a lot of people who don't want to change the system, but it's not real.